Hello coders, today we're talking about respiratory surgery coding for CPT. Like we found with integumentary and musculoskeletal, we will also find the three easiest ways to search for these codes. The first one is by the procedure name, like a thoracostomy. We can look up the phrase thoracostomy. An anatomic site, so we can look at the nose, we can look up lung, we can look up sinus, we can look up larynx, we can look up epiglottis. Or the condition. There are some condition codes, such as cleft lip. You can look up cleft lip instead of looking up repair cleft lip. Okay, so here are some of the big ones that you're going to see for main terms. If we're dealing with the nose, look up nose. You can also look up lip, cleft lip. Foreign body is a big one because we remove foreign bodies from the nose. Nose bleeds, we pack those. Different ablations, lavage. Lavage is washing. It's usually what they describe it as infiltrating the site. And what we mean by that is we're usually taking a saline solution and we're cleaning out the area. But on occasion, a lavage can be done with another type of chemical that will better clean out the system. And that's really up to the doctors to decide if it's going to be a medication lavage or if it's just going to be cleansing the area. Just like when we were talking about debridement, cleansing and washing of the skin, this is the cleansing and washing of an area of the respiratory system, such as the nose or the sinus cavities. Of course, endoscopy. Why? Because we're going inside the respiratory system. Remember, respiratory system starts at the nose and ends up at the alveoli, those little air sacs where the blood-air exchange happens in our lungs. So we have to remember, as we're going down, we're going inside the body. Of course, you can look up sinus. We have a lot of sinusoscopies and sinusotomies. Now, I know it has a red squiggle, but that's because it is not in the dictionary for this version of word, but trust me, those are the correct spellings. Even though they look wrong, they are the correct spelling. So sinusoscopy, scoping directly into the sinus. Sinusotomy, making an incision into the sinus. Of course, we can also look up larynx, okay, our throat. Intubation, which is establishing an airway. Trachea. Bronchi or bronchus. Remember, we go back to med term. Remember, when we're talking about one part of the body, and then we're talking about the other side. So we have bronchi if we're talking about one side, and bronchus, US, if we're talking about both sides. Okay, we're all going to see things like tracheostomy. Okay, so again, making a new opening into the trachea. Bronchoscopy, scoping all the way into the bronchus, into the lungs. Of course, lungs, another big one. Pleura, don't forget that even though the respiratory system ends at those air sacs, what surrounds the respiratory system is that double folded membrane called the pleura. And again, we can do procedures on the pleura, and a lot of times we have to go through the pleura to get to the lungs if we're going from the outside of the body. We're also going to be talking about thoracostomies, okay, so making a new opening, versus thoracoscopies, which is when we're scoping into the thoracic cavity. And then at the end, our transplantation for people to get lung transplants. So let's keep all these main terms in mind as we're going through. Now, the first thing that you'll notice is there are no guidelines for nose, but there's a lot of little bits of information. So the first thing I want to point out right here, 30000, drainage of abscess or hematoma, nasal internal approach. For external approach, see 10060 and 10140. So they're giving us a reminder here that if we're going inside the nose to drain an abscess or hematoma, it's going to come from the respiratory system. If it's on the skin on the outside, then it's going to come from integumentary. Same thing with the lips and the eyelids. If it's surface on those part of the bodies, then it's going to come from integumentary. If it's deep, or in case of the nose, inside, it's going to come from respiratory. And again, a good main term here is nose. We can also look up things like rhinectomy. You will find that code there. Remember, introduction, we are introducing something to the body. The big one is right here, 30220, insertion of a nasal septal prosthesis button. This is also known as a nasal button. And what this is usually it's made out of a plastic-like material, a little bit flexible. This can be used for a couple of different purposes. One of the big ones is piercings, when people pierce their nasal septum, and as they grow older, they can have issues with breathing and sleeping, so they get the nasal button put in, it closes up the area. Also, people that have snorted different types of drugs, it can wear out the skin in that area as well. Those are the two big ones. But of course, traumatic accidents and injuries and things like that can lead to nasal buttons. Now, when we get to removal of foreign body here, okay, we have a couple different types. So we have 30300, removal of foreign body intranasal office type procedure. And then the indented codes are requiring general anesthesia or bilateral rhinotomy. So if little Billy sticks a Lego up his nose and the doctor can go in with a pair of forceps or tweezers and pull it out, that's 30300. But if, let's say, that Lego piece is not coming out, and they have to sedate little Jimmy to make sure that, he's not going to fuss too much because it may hurt pulling it out, then we'll do 30310. If the object is so large or they can't pull it out even under general anesthesia without ripping or tearing part of the inside of the nose, that's where we're going to do the lateral rhinotomy. We make an incision on the side of the nose, and then we go in and grab the foreign body. A couple of things I want to show you guys. Again, there's no guidelines, but this is important to know. Again, the different types of rhinoplasties, these are nose jobs. But again, why are we doing them? So we could be doing them because of a nasal septum disorder where the septum is deviated, meaning it doesn't go back straight, kind of S-shaped or squiggled, which can lead to breathing difficulties and sleeping difficulties with snoring. But we also do this to fix different types of congenital anomalies. So that's where we're going to see 30460. Rhinoplasty for nasal deformities secondary to congenital cleft lip and or palate. And this includes columnar lengthening tip only. And again, when we're coming with congenital anomalies, we're talking about what the baby was born with. And so again, this is more of a reconstructive procedure instead of something that's more of a beautifying procedure. Now, that's not saying that people cannot get a rhinoplasty done for cosmetic reasons. They absolutely can. We use the same exact codes. The difference is insurance almost never pays for cosmetic surgery. Again, it depends on the medical necessity of it. All right, so I want to show you guys, so this is going a couple pages back. We're now in the sinuses. So we're past nose, we're now into sinus. And these are the endoscopies. So these are scoping up into the nose and looking in the sinus cavities. So it first tells us a surgical endoscopy always includes sinusotomy when appropriate and a diagnostic endoscopy. So I said this in the last one, I will continue saying this. All surgical scopes include a diagnostic scope. However, in this case, it doesn't just include a diagnostic scope, it also includes an incision into the sinus cavity. So be careful, always know what's included in your codes before you code them. Then we have some more specific information about some new codes they put in. Codes 31295 to 31298 describe dilation, so opening, of the sinus ostia by displacement of tissue, any method, and includes fluoroscopy if performed. Okay, so a couple things. Number one, dilation, widening or opening an area. Okay, and we're doing this of the sinus ostia, so the sinus tissue, and we're displacing the tissue. So again, we're opening the area and we're removing tissue by any method that the doctor wants to do. Now, it includes fluoroscopy. Remember, fluoroscopy is basically when the patient is on the operating table and sitting above them is X-ray equipment. Now, the X-ray equipment is not taking pictures. What it's doing is it's sending a live feed to the doctor on a computer or TV screen so they can see what's going on. So as they scope in, part of the scope has metal and they can see the scope as they're going in for these procedures. So keep that in mind. Now, it does have a code that might go with it, because remember, sometimes we have to use surgical codes for more than one section. So stereotactic computer-assisted navigation may be used to facilitate the performance of endoscopic sinus surgery and may be reported with 61782. So stereotactic computer-assisted navigation is a way of looking at the body in a different way in an updated version of imaging. So it just gives the doctor a slightly better picture of what they're looking at. So again, they're telling us right here, be on the lookout. Doctors are using stereotactic computer-assisted navigation with a lot of these surgeries. Okay, now this is also important. 31233 to 31298 are used to report unilateral procedures unless otherwise specified. Okay, so this is what we haven't talked about yet. Okay, again, remember we have two sets of sinus cavities, one on each side. We have 4 sinus cavities altogether. We need to know which sinus cavity, and we need to know LT, RT, or modifier 50. So keep that in mind. Again, we have bilateral sinus cavities, and then as we go down, we're going to have our lungs as well. So now they're telling us what they might be looking for in these codes. Codes 31231 to 31235 for diagnostic evaluation refer to employing a nasal or sinus endoscope to inspect the interior of the nasal cavity and the middle and superior meatus, the turbinates, and the sphenoethmoid recess. Okay, so we're going in, we're looking at the cavity, we're looking at the openings, we're looking at the turbinates, which are the bones in the nose, and the sphenoid-ethmoid recess, which is where the sphenoid and ethmoid sinuses are. Anytime a diagnostic evaluation is performed, all of these areas would be inspected, and a separate code is not reported for each area. So again, we can look at all of this as part of a diagnostic, because what are we doing in diagnostic? We're looking around. So, to report these services when not all of the elements are not fully examined, like judged not clinically pertinent, or because of a clinical situation precludes such an exam, such as technically unable or altered anatomy, append modifier 52 if a repeat examination is not planned, or modifier 53 if a repeat examination is planned. Okay, so let's go back. So first of all, to code these codes, we need to make sure they're looking at all these areas, okay? They're looking at the cavity, they're looking at the meatuses, they're looking at the turbinates, they're looking at the sphenoid-ethmoid recess. If they cannot look at one of those, let's say there is a tumor in the ethmoid recess, okay? They're not going to be able to get in there. So what we need to know is, number one, is it documented why they couldn't get there? And number two, are we going to repeat this examination or not? Now, I don't want anyone to panic because remember, we always code after the fact. So we're always going to code after the patient has already left the facility. So the doctor's going to need to tell us repeat or not. So modifier 52, if we're not repeating, is for reduced service. Why? Because we could not see all the areas, so the doctor will not get paid up at 100%. Modifier 53 is saying discontinued, meaning we have to stop the procedure because of an issue. So when we do a repeat, the insurance company does not ask us, why are we repeating this? Because they'll pay us up until when the procedure had to stop, and then for the second procedure, they will pay in full as well. Now, I want you to be careful. Because right here, 31231 nasal endoscopy diagnostic, okay? And then again, diagnostic. But when you get to the next page, that's where you're going to see some surgical. So kind of keep that in mind, okay? All right. Now we get to the larynx. So again, the larynx, we can look up the word larynx, or we can look up the type of procedure like a laryngectomy. Remember, when you see things like with radical neck dissection, what they're talking about is removing surrounding tissue and lymph nodes. A lot of times when you see these radical neck dissections, it's due to one of two main things: extensive traumatic accident or injury, or a malignant neoplasm, cancer. Cancer is the most common cause for these types of issues, okay? So we can always look up the name of the procedure, but I want to show you guys. Okay, code 31500. This is one of our few codes that has the no symbol in front of it. And the reason why it has the no symbol is we don't add modifier 51 to this code. The reason we don't is because we get paid in full at 100% no matter what we're doing with this procedure. Because this procedure, 31500, is intubation. It's establishing an airway for a patient who cannot breathe on their own, okay? Now, Intubation can be done in a variety of circumstances. Number one, it can be done absolutely in the hospital during a surgery before the patient goes into respiratory arrest. They can quickly do an intubation. Most of them are going to be emergency. So the patient is having a problem breathing, we have to intubate them. But this also happens a lot on the ambulance or on LifeStar. Now, one of the interesting things that Connecticut does is if you are on LifeStar, there are 3 people who are on LifeStar with the patient. There's the pilot, there is a provider, and there's a respiratory therapist. Because the provider, I should say, is usually more of a paramedic or EMT. However, a respiratory therapist can intubate a patient. That is within their scope of practice. A paramedic or EMT cannot intubate a patient without doctor approval. And that's why we have that special evaluation and management code for when the doctor is in two-way communication. Because the doctor at the receiving facility can tell the paramedic or EMT, yes, you can intubate the patient, and anything that goes wrong, I will take responsibility for. So intubation is almost always emergency. There is a planned intubation code as well, and that's going to be more for people that we know ahead of time we have to establish the airway for a surgery. But this is the emergency procedure, and you can always look up the main term of intubation. Remember, this is endotracheal. Within the trachea, we're establishing that airway to keep the throat open. Now, just like our sinusoscopies, our laryngoscopies also have very similar guidelines. They're going to tell us what's included, and they're going to tell us whether or not we might use other types of equipment. So, for endoscopic procedures, report appropriate endoscopy for each anatomic site examined. Okay, so a laryngoscopy includes examination of the tongue base, larynx, and hypopharynx. The anatomic structures examined with this procedure include both midline, single anatomic sites, and paired structures. Midline single atomic sites include the tongue base, the vallecula, epiglottis, subglottis, and the posterior pharyngeal wall. Paired structures include the true vocal cords, the arytenoids, false vocal cords, ventricles, and piriform sinuses, and artioepiglottic folds. For the purpose of reporting therapeutic interventions, all paired structures contained within one side of the larynx or pharynx is considered unilateral. If using an operating microscope or telescope or both, use the applicable code only once per operative session. Okay, so this is something a lot of people tend to forget about, because when you look in your CPT book and you look at the respiratory system, it's very small, it's very direct. So let's see if we can find a better picture of this. So what we're gonna do, I'm gonna go right to Google, and I want a picture of the larynx. And this is all I do. I just search for it, and I usually, if there's an image that pops up, great. If not, I usually go under Google Images. You can use Bing, you can use Yahoo, whatever you like. Let's see if we can get a nice image of it. Okay. So again, we've got a lot of different pieces here. Oh, hold on. This one actually looks good. Sorry. Oh no. There we go. And again, all I do is I just like to look. I'm not going to copy this or anything like that. Let's just kind of look at it. So again, you can kind of see we have the epiglottis is up here. Remember, the epiglottis is that flap of muscular tissue that allows us to breathe when it opens and flaps shut when we need to swallow or eat something. So again, they're talking about both sides, and you can see right here we have 2 sides of either of these. And so again, we have paired and we have non-paired. So if you're working for respiratory, you're going to need to become very familiar with the different parts of each system. In this case, the larynx has a lot of different little parts in it that people forget, just because we just think, oh, the larynx, it's our windpipe, that's it. But there's so many structures within here, including our vocal cords, which again, our vocal cords come out from either side. They are bilateral. So again, always feel free, You can always, there's a lot of good pictures on Google, and depending on which ICD-10 book or HCPCS you might be using, you may have anatomical pictures in there too. So here's the thing. We have direct and we have indirect laryngoscopies, okay? Indirect laryngoscopies mean that we're going up the nose and then down into the respiratory system. Versus direct means we're going in the mouth and then direct down the respiratory system. So again, for laryngoscopies indirect, they need to tell us, okay, what are we doing with it? If we're just looking around, it's a diagnostic. If we're removing a foreign body, now it becomes surgical. So we have indirect, we have direct, again, we even have for newborn, and be careful. A lot of times when the code descriptor uses the word newborn, we can't use modifier 53 with it. So always be looking out for those types of notations. And look right here, we have a diagnostic with operating microscope or a telescope. So it's one code, it's not a separate code that we have to add on if we use an operating microscope or telescope. And so again, are we doing a sinusoscopy? Are we doing laryngoscopy? Or, as we're going to see here, are we doing a bronchoscopy? So as we continue to go through the system, now we're going into the bronchus, so we're going into the actual separate tubes that go into each lung, and it tells us, for endoscopy procedures, code appropriate endoscopy for each anatomic site examined. Surgical bronchoscopy always includes diagnostic bronchoscopy when performed by the same physician. So that's important. As long as it's the same physician, it's included. Now, then they also tell us 31622 to 31651 and 31660 and 31661 include fluoroscopic guidance when performed. So remember, if we're using fluoroscopy, it's included. It's not a separate procedure. We also have codes 31652 and 31653. These are complete services for sampling what we call aspiration or biopsy of lymph nodes or adjacent structures utilizing what we call EBUS, endobronchial ultrasound, okay, and are reported separately. So EBUS is used more for when there is an issue with the lymph nodes or there's cancer and we have to go in and sample those areas. Code 31654 is an add-on code that should be reported for identifying one or more peripheral lesions with transendoscopic ultrasound. So again, what's included in the codes in general, and then what is included in the code descriptor. Now, the first code you're going to see here is a tracheobronchoscopy through an established tracheostomy incision. What this means is we're scoping through the opening of the trachea. The patient already has a tracheotomy, okay, or tracheostomy, sorry. They have an opening. So we scope into that opening. As we get into other body systems, we're going to see a lot more of this. If someone has a new opening from a part of their body to the outside, we're going to scope into that versus scoping in a natural orifice most of the time. And usually it's because we can't access the organ most of the time. So like for instance, if someone has a colostomy, it means that they have part of their colon coming out to the body. Usually that's because we're not going in the anus and rectum because of an issue, such as cancer. So again, we need to be careful. This is a tracheobronchoscopy. And then the second code is the regular bronchoscopy. And again, we can use a rigid or a flexible scope with most of these. And again, this is the diagnostic. Now the diagnostic also includes cell washings, which means we kind of wash the area a little bit. So again, we need to be careful. What's included in our codes? What did our doctor do? Okay, so as we end the trachea, we get to the lungs and pleura, okay? So we have something called VATS, video-assisted thoracoscopic surgery. So this is when we're basically using a super-powered microscope that, again, attaches to a computer screen or a large TV so we can see what's happening inside the patient. But we can also do them percutaneously, going through the skin, or, as it continues on to the next page, a thoracotomy, which is when we make an incision into the thoracic cavity, and then we can stick our instruments into. It all depends on what the provider wants to do and what the patient needs. Regardless, all three of these techniques, they involve the removal of differing amounts of tissue for diagnosis. Now, a biopsy may be performed using different techniques such as incision or wedge. Lung resection procedures include diagnostic and therapeutic procedures, and includes the removal of blebs, bullae, cysts, and benign or malignant tumors or lesions. These procedures may involve the removal of small portions of the lung or even an entire lung. Additionally, lung resection procedures may require the removal of adjacent structures. So, I'm going to bring up my little paint here so I can give you guys an idea of what we're really looking at when they're talking about these. So, okay, it goes on. Additionally, lung resection procedures may require the removal of adjacent structures. Again, structures right next to it. Now, both diagnostic lung biopsies and therapeutic lung resections can be performed utilizing a wedge technique. I will show you what that looks like. However, a diagnostic biopsy of a lung nodule using a wedge technique requires only that tissue samples be obtained without particular attention to resection margins. Why? Because it's diagnostic. We're trying to diagnose what's wrong. So we're not going to do that surgical pathology. We run it down like we do sometimes in integumentary. But a therapeutic wedge resection requires attention to margins and complete resection even when the wedge resection is ultimately followed by a more extensive resection. Because when we're doing a therapeutic, we know what the problem is. We're doing a therapy, okay? However, it goes on. In the case of a wedge resection in which intraoperative pathology consultation determines that a more extensive resection is required in the same anatomic location, it becomes classified as a diagnostic wedge resection. Okay, so again, we need to know what happens after intraoperative pathology if that's the case for the patient. When no more extensive procedure is required, the same procedure is a therapeutic wedge resection. Okay, so let's bring up my little paint here. Okay, there we go. So I'm going to see if I can do this. Okay, so we have our lungs, lung here, we have a lung here, and we have 3 sections, okay? So up here, this is the right upper lobe right here. This is the right middle lobe and the right lower lobe. The left lung has the left upper lobe and left lower lobe because we need to have room for the heart to fit in here, okay? So when we're talking about the lungs, although they are bilateral because they do have 2 sides, they are not equal, okay? So the right lung has 3 lobes, the left lung has 2 lobes. Okay, so I'm going to erase all this. Now let's talk about those wedge resections. Okay, so what we're basically doing in a wedge resection is, think of it like a wedge of cheese. Okay, so let's see, I'm going to get the lung back here. Okay, oh, much thicker than I want. I want just a, there we go, a pencil. So here's one lung. There's the other one. Now, if we're doing a wedge resection, a lot of times what they're going to want to do is they're going to take out a little wedge. Okay, so this whole wedge would get removed. Now, if it's a diagnostic wedge resection, we're just removing the tissue because we've seen something, we want to see what it is. However, if it is a therapeutic, we already know what the problem is and we go in and remove it. We have to look at the margins. Again, remember the margins are the edges of the tissue. Because if we already know this is malignant, if we didn't get all that malignant tissue out, we're probably going to have to go back in and do another procedure. So just kind of keep that in mind, okay? So when we're talking about bullae, blebs, cysts, those are all different types of growths we can have in and on the lungs, which are similar to the nodules we see on the skin, but obviously they're on the lungs instead of on the skin. So, that's something that we want to think about, okay? Although our lungs are bilateral, we have 5 lobes, not 6. And the wedge resections are taking out a piece. Now, it goes on, continues to go on, which says, I want to start right up here. Okay. More extensive anatomic lung resection procedures, which can be performed either thoracotomy or thoracoscopic VATS approach, include segmentectomy, lobectomy, bilobectomy, and pneumonectomy. So a segment is we're taking out like a little wedge, like a little segment, like we just saw. A lobectomy, we're taking out an entire lobe of the lung. Bilobectomy, we're taking 2 lobes of the lung. And pneumonectomies, we're taking out an entire lung. So again, what are we doing? So when diagnostic biopsies of the lungs are performed regardless of approach, open, thoracoscopic, or VATS, or the technique they're using, incisional resection, cautery resection, or stapled wedge, and the specimen is sent for intraoperative pathology consultation, during the same operative session, the surgeon uses the results to determine the extent of the necessary surgical resection that includes anatomical location biopsied. Only the most extensive procedure performed should be reported. So this is just like when we're doing the malignant lesion removals from the body, okay? When the patient is still on the table and we've gotten back the intraoperative pathology and we have to go back in and remove more tissue, we only code it once to the final one, whatever the final procedure was. So again, most extensive procedure is the only one that will get coded when we're going back in after intraoperative pathology. Couple things I want to show you guys though. Number 1, code 32551, tube thoracostomy. This is a chest tube. So this is when they're putting a tube into the chest cavity for drainage. So a lot of times what happens is the chest cavity or the pleural cavity or the lungs themselves start building up with fluid. And again, it can be all different types of fluid. Hopefully it's not pus, but on occasion it is pus with bacteria in it. And what we do is we just allow it to drain outside of the body. But if you look up chest tube, you're not going to find it. Why? Because it's a tube thoracostomy, because what we're doing is we're sticking a tube into a new opening in the thorax, which is what the thoracostomy means. Stomy, new opening, thoraco, thorax. And then we're allowing it to drain. This is one you'll see quite often. So I made a little star. I know you can't see my whole star, but it is there, just to remind yourself of that code. There's a couple other little guidelines. We have some destruction procedures. And so this is for people that are having specific areas of what we call multiloculated effusion. So again, this could be a buildup of pus. This could be a buildup of mucus. This could be a buildup of something else because of a disease condition. So the installation of a fibrolytic agent. Okay, so let's go back. Installation, we are placing something inside an area. Fibrolytic, lytic, breakdown, fibrino, fibers. So we're helping break down the fibers of whatever is hanging out in this area. This may be performed multiple times per day over the course of several days. So they're telling us this is not a one-time deal. Code 32561 should be reported only once for the initial day of treatment. Code 32562 should be reported only once on each subsequent day of treatment. And again, you can see here. And then for chest tube insertion, so they're telling you right away that these installations right here, this is something that we tend to do with a chest tube, which is why there's a notation underneath it. And again, for this one, you can look up installation or you can look up destruction. Again, the thoracoscopic VATS, so it reminds us surgical thoracoscopy always includes diagnostic thoracoscopy. And when we talk about cardiology, guess what? We can still use these codes because we're going into the same body cavity, no matter whether we're dealing with the heart or the lungs, which is why you'll see thoracoscopy diagnostic. This is the lungs, pericardial sac, mediastinal or pleural space without biopsy. We can go into the pericardial sac. Remember, that is the membrane sac that surrounds the heart, pericardial surrounding the heart. And then, of course, we can also just do the regular thoracoscopy. And again, we can do a wedge or incisional. And of course, we also can go in and we can remove a lobe, 2 lobes, or a lung. Again, we have a diagnostic biopsy here of a lung nodule or mass. We have a surgical thoracoscopy here. And again, what are we doing with it? Are we just doing the surgical with the pleurodesis, or are we doing something else? We always need to know, what are we doing along with the procedure to see if there's an indented code that best describes what we're doing. Then we get to what we call the thoracic stereotactic body radiation therapy, which is SRS SBRT. Now, again, as it tells us, it is a distinct procedure which may involve collaboration between surgeon and radiation oncologist. The surgeon identifies and delineates target for therapy, and the radiation oncologist reports the appropriate codes for clinical treatment planning, physics, and dosimetry. So this is for the surgeon to say, hey, these are the areas that we want you to treat. And as we see these codes, it goes on to tell us. So again, it tells us target delineation involves specific determination of tumor borders to identify tumor volume in relationship with adjacent structures, such as the chest wall, the intraparenchymal vasculature, or an atelectasis lung, and previous placed fiducial markers when present. So target delineation also includes availability to identify and validate the thoracic target prior to treatment delivery when a fiducialist tracking system is utilized. So again, this is what the doctor's doing. They're going in there, they're identifying the tumor, they're identifying how close it is to the adjacent structures, and they're placing markers if need be. Now again, they tell us, do not report target delineation more than once per entire course of treatment when the treatment requires greater than 1 session. So again, this is a one-time deal, and it tells us the codes for the placement of those fiducial markers. Last section is transplantation. We always have 3 parts of transplantation. We always have the removal, the backbench work, and the transplant itself. So they tell us cadaver donor pneumonectomy, which includes harvesting of the allograft and cold preservation of the allograft. So this is removing the lung and making sure that we're going to stabilize the tissue in a cold environment until it gets to the person who's doing the backbench work. Now, preparation of cadaver donor single lung allograft prior to transplantation includes the section of the allograft from surrounding soft tissues to prepare the pulmonary, venous, atrial cuff, pulmonary artery, and bronchus unilaterally. However, if it is a double lung allograft, again, it's going to be very similar, but it's going to be the bronchus bilaterally. So we need to know if this is a pneumonectomy or a double pneumonectomy. And then the allotransplantation, again, we need to know who's doing what portion. Sometimes this is 1 doctor, sometimes it's 2, sometimes it's all 3. So what is your doctor doing for the transplants? So as a reminder and a review, don't forget, easiest ways to find these codes under the name of the procedure, the direct anatomic site, and on occasion, the condition. Okay, and don't forget to make sure when you're looking through that you are pulling out the code for the exact procedure that we're doing. So sometimes that will require you to flip back a page to get back to the standalone code to make sure you are getting the correct indented code. All right, have a great day.